levels from primaries to diploma to membership/part 1 level as well as part 2 level. Today we shall be dealing with a subject which affects all of us at every stage, that is ambulatory anesthesia and current concepts. I would like to invite, without wasting time, Dr. Osaheni, who is the consultant anesthetist in Federal Medical Center, Asaba. Am I correct, Dr. Osaheni?
No, UBTH.
No, he's a consultant anesthetist at UBTH. I'm sorry, please. And he will be introducing the speaker to us. Thank you very much. Please enjoy your session.
Thank you very much, Ma, for that wonderful introduction. I want to, on behalf of the president, welcome everybody to this webinar. We'll be looking at ambulatory anesthesia current concept. The presenter is no other person than Dr. Aniobi Vernatius Aniobi. He's a fellow of West Africa College of Surgeons. He trained at University of Port Harcourt Teaching Hospital, worked briefly at Federal Medical Center, Owerri as consultant anesthesiologist. He then proceeded back. He returned back to University of Port Harcourt Teaching Hospital, where he is currently working. His area of interest is strengthening the anesthesia team and training. Dr. Aniobi, you are welcome. The stage is set. You can start the presentation, sir.
Yes, Dr. Adesina will be sharing screen, please.
My teachers, senior colleagues and colleagues in Nigeria and in diaspora. I am Dr. Aniobi Vernatius Aniobi. I'm going to present a topic on ambulatory anesthesia. It's going to be on the following outline: the definition, facility design, procedures for ambulatory anesthesia, benefits of ambulatory anesthesia, selection of patients, preoperative assessment, types of techniques for ambulatory anesthesia. Then I will conclude. By way of definition, ambulatory surgery, ambulatory anesthesia surgery, is a type of surgery in which patients present to the hospital is going to be on the following outline: same day, definition, facility design, surgery, procedures for ambulatory anesthesia, benefits of ambulatory anesthesia, of selection of patients, preoperative assessment, types of techniques for ambulatory anesthesia. Then I will conclude. Anesthetist with the dual goals of rapidly and safely establishing surgery, ambulatory anesthesia of therapy is the type of surgery in which patients, while present to the
What happened? Just wait. Just wait.
The rate of ambulatory surgery has increased steadily because of the continued improvement in anesthesia techniques, such as the use of regional anesthesia and the availability of ultrashock acting anesthetics with reduced side effects. Also, increased rate of minimally invasive surgical techniques have also increased the use of ambulatory anesthesia. The rate of ambulatory surgery design has increased this steadily because of the continued improvement in anesthesia techniques, such as the use of regional anesthesia and the availability of ultra-short acting anesthetic to reduce side effects. Also, increased rate of minimally invasive surgical techniques. Same surgery also increased the usual technique, so share no space or patient care. Pre-operative increased rate of minimally invasive surgical technique within the autonomous unit. Then in the office base, the diagnostic suites are being managed by the physician in his office for convenience of the patient and the healthcare providers. Procedures suitable for ambulatory surgery. This cuts across various also special increase the usual technique, so or patient care can be done pre-operative increased rate of within the autonomous unit. Then in the office lesions, the general diagnostic suite biopsy excision are being managed by the physician in his office for convenience of the patient and the healthcare providers using ambulatory anesthesia. Procedures suitable for ambulatory surgery. In this cuts across various also increase polypectomy or uterine polypectomy can be done as ambulatory surgery using ambulatory anesthesia. Ophthalmology, cataract excision, extraction, pterygium excision, and the strabismus surgery can be done as ambulatory surgery. In orthopedics, the shoulder reconstruction, close reduction, minimally invasive hip replacement surgery are all done under ambulatory anesthesia. Or uterine polypectomy can be done as ambulatory surgery using ambulatory anesthesia. Ophthalmology, cataract excision, extraction surgery, pterygium excision procedures and the strabismus surgery can be done as ambulatory surgery. Sympathectomy, way of epidural injection, orthopedic in which patient presents to the hospital and returns home same day after the procedure and the day or the surgery. Therefore, ambulatory anesthesia is the administration of anesthetics with the dual goals of rapidly and safely establishing satisfactory condition for the performance of therapeutic or diagnostic procedure while ensuring rapid, predictable recovery with minimal post-operative side effects in patients having ambulatory surgery. The rate of ambulatory surgery has increased steadily because of the continued improvement in anesthesia techniques, such as the use of regional anesthesia and the availability of ultrashock acting anesthetics with reduced side effects. Also, increased rate of minimally invasive surgical techniques have also increased the use of ambulatory anesthesia. Facility design. This can be hospital integrated, hospital-based, freestanding, office-based. For hospital integrated, ambulatory surgical procedures are managed in the same surgical facility, in the same surgery facility as inpatient. While in the hospital base, a separate ambulatory surgical facility within a hospital handles the outpatient only. Then the freestanding surgical and diagnostic facilities may be associated with hospital or medical center, but are housed in a separate building that share no space or patient care. Pre-operative evaluation, surgical care, and the recovery occur within the autonomous units. Then in the office base, the diagnostic suites are being managed by the physician in his office for convenience of the patient and the healthcare providers. Procedures suitable for ambulatory surgery. This cuts across various specialties in medicine. Dental, for instance, extraction of tooth and restoration can be done as an ambulatory surgery, employing ambulatory anesthesia. Dermatology, excision of skin lesions, general surgery, biopsy excision, endoscopy, and colonoscopy, cholecystectomy can be done as ambulatory surgery using ambulatory anesthesia. In gynecology, dilatation and curettage, hysteroscopy, vaginal hysterectomy, or uterine polypectomy can be done as ambulatory surgery using ambulatory anesthesia. Ophthalmology, cataract excision, extraction, pterygium excision, and strabismus surgery can be done as ambulatory surgery. In orthopedics, the shoulder reconstruction, close reduction, minimally invasive hip replacement surgery are all done under ambulatory anesthesia. Otorhinolaryngology, adenotonsillectomy, rhinoplasty, and tympanoplasty are all done as ambulatory surgery. Procedures, a pain clinic, when chemical sympathectomy, way of epidural injection of pain drugs can also be done as ambulatory procedure. Plastic surgery, basal cell cancer excision, cleft lip repair, then in urology, bladder surgery, circumcision, orchidopexy. These are all ambulatory surgeries that can be done under ambulatory anesthesia. There are benefits that are derived from ambulatory anesthesia. These include lack of dependence on the availability of hospital beds. It offers greater flexibility in scheduling operation, because a lot of patients are usually on the list waiting to be operated on. By way of doing ambulatory surgery, this patient can be done without waiting for a long time. It offers low morbidity and mortality. There is low incidence of infection because these patients are not admitted overnight in the hospital, so they don't acquire hospital-acquired infection. Lower incidence of respiratory complication, higher volume of patients, shorter surgical waiting list, because in the inpatient, there are usually a lot of patients line up for surgery, but with the ambulatory surgery, this can all be cleared and the patient will be operated on and they go home same day. Lower overall procedural cost and less pre-operative testing and post-operative medications. Then the selection criteria. This can be based on patients, families, our social factor, the procedure, and anesthetic consideration are factors. In patients, ASA physical status, it used to be said that ASA 1 and 2 are the patient fit for ambulatory anesthesia. But presently, ASA 3, who are medically stable, can also undergo ambulatory anesthesia, so long as those patients are health conditions, medical conditions are under good control for at least 3 months before the operation. Even morbid obesity of BMI greater than 40 kilograms per meter square is no longer considered as an exclusion criteria for ambulatory anesthesia. Also, age. Age is not a barrier for patients who want to undergo ambulatory anesthesia, as long as there is no comorbid state, or even if there is, those morbid states are post-conceptional age, because they will be prone to post-operative apnea. So that should be taken care of before considering ambulatory anesthesia. Social factors. The patient must be prepared to have the procedure performed as decades to hospital with a responsible adult carer at home who will be with the patient 24 hours post-operatively. And the patient should live close to the hospital, at least within 1 hour drive to the hospital. Patients should not be allowed to drive or operate any machine within 24 hours post-operatively. And it should have easy access to functional telephone after discharge to communicate to the doctor. Then procedural stroke surgical factors. The surgery or the procedure should not last longer than 90 minutes. And there should be no risk of excessive hemorrhage. And there should be no associated post-operative pain. In case abdominal cavity is to be opened up, it has to be done using laparoscopic or minimally invasive technique. Patients should be able to resume normal function, that is oral drinking, as soon as possible after the procedure or the surgery. The surgeon to do this ambulatory surgery should have sufficient experience doing day case surgeries. Then anesthetic factors. Experienced anesthetists should conduct ambulatory anesthesia. You must ensure that there is no difficult airway for the patient undergoing ambulatory anesthesia. Avoid the use of anesthetic drugs that will have prolonged action. Also avoid drugs that will have some side effects such as post-operative nausea. Ensure that patient history is taken. If the patient has had anesthetic problems such as malignant hyperthermia, you have to rule it out. Then there are contraindications to having ambulatory anesthesia. Potentially life-threatening chronic illnesses. such as uncontrolled diabetes, unstable angina, symptomatic asthma should not be subjected to ambulatory anesthesia. Less than 60 weeks home, who will stay and care for this patient, especially first 24 hours post of surgery. That patient should not be considered for ambulatory surgery. Preoperative assessment. The three primary components of preoperative assessment comprises the history, which have the greater percentage, physical examination, then laboratory testing. Sometimes computerized questionnaire can be used to prepare this patient via telephone, which can be conducted by a trained nurse. Anaesthetic clinic is very important so that the patient will know the day for the surgery to avoid unnecessary delays and the patient not presenting for the procedure. Preoperative preparation will involve the patient being encouraged for those who have chronic medical condition to continue the medications they have been on up until the day they will arrive for surgery. Oral medication can be taken that morning of the procedure using sip of water, even up to 1 hour before the procedure. There are some non-pharmacological preparations, such as explaining verbally the instructions regarding the time the patient should arrive to the place of the procedure, the fasting guidelines, because this patient should also obey the fasting guidelines, such as avoidance of water 2 hours before the procedure, then oral solid feed 8 hours. Then information concerning the post-operative course should be explained to the patient. The effect of the drugs should be explained to the patient so that he will avoid driving or performing cognitive skills first 24 hours post-procedure. The need for responsible adults within the 24 hours post-procedure is very important and will be communicated to the patient. Like I said earlier, fasting guidelines should be explained to the patient and the patient should follow it strictly. Knowing that hunger, thirst, hypoglycemia can cause severe discomfort. So this patient should not be kept longer than necessary when they present for the procedure. There are some pharmacological preparation prior to the day of the surgery because there's routine prophylactic acid aspiration is no longer recommended. However, if there is need or risk, histamine receptor antagonists such as ranitidine can be given 50 milligrams intravenously. Proton pump inhibitors such as omeprazole 40 milligrams intravenously can be given. Non-particulate antacid 0.3 molar sodium citrate 30 ml orally can be given. Then prokinetics such as metoclopramide 10 milligrams can be given. This will help to prevent the risk of aspiration. Also, there's need to prevent post-operative nausea and vomiting by giving some prophylactic agents like serotonin antagonists like ondansetron 0.1 milligram per kilogram body weight, anticholinergics, atropine 0.02 milligram per kg, butyrophenol, example, droperidol, less than 10 microgram per kg, or steroid like dexamethasone 0.1 microgram per kg. This can be given to help prevent post-operative nausea and vomiting. Then, anesthetic techniques. The general principle is the same. There need to ensure rapid recovery and the use of short-acting drugs to because this patient will go home after the procedure, after the ambulatory anesthesia is conducted. Techniques available for ambulatory anesthesia include general anesthesia, regional anesthesia, monitored anesthesia care, local anesthesia or local infiltration, intravenous regional anesthesia, otherwise known as Beer's block, and peripheral nerve block. The general anesthesia, airway management is important. Selection of induction agents also is very important. Therefore, propofol is the best intravenous. Then you can use inhalational agents such as sevoflurane. Use of muscle relaxants can also be used. Mivacurium, suxamethonium. But note that when these drugs are to be used, you must have the antagonists such as naloxone, flumazenine, neostigmine, and sugar mothers. They should be available before you start your procedure. There are qualities of an ideal ambulatory anesthetic agent. The onset of action should be fast and be predictable. Elimination should also be rapid and predictable. You can easily titrate depth of anesthesia. There should be no active metabolites that can cause prolonged action. The drug shouldn't accumulate and be released later to cause complication. There should be no pain on injection. The inhalation should not cause irritation when a patient is inhaling it. Then the side effect profile should be good, and the drug should not cause postoperative nausea and vomiting. Monitoring is sane and important even when you are conducting ambulatory anesthesia. The use of multi-parameter monitor that can monitor the ECG, pulse oximetry, non-invasive blood pressure, end-tidal CO2 are all important. It is also good to monitor the end-tidal concentration of inhalational agent. This will help you to keep your patient safe during the ambulatory anesthesia. Induction, like I said, sevoflurane is the first choice inhalational induction agent because it has pleasant odor, is non-irritating, and it has rapid onset and fast recovery. Propofol is the first choice intravenous induction agent. It's very smooth. Then you need to maintain the anesthesia. Use of air and oxygen is better compared to use of oxygen and nitrous oxide. Then also use your volatile agent to maintain, and the best is sevoflurane and desflurane. They have rapid recovery and high incidence of, there's no high incidence of emergency agitation. You can use your total intravenous anesthesia with propofol alone. It is very advantageous because patient wakes up smoothly at the end of the procedure. Also, maintain analgesia using the analgesics. Use multimodal. Avoid the use of opioid because of its side effects such as post-operative nausea and vomiting. Emergency recovery of psychomotor function are faster with fentanyl compared to fentanyl. Like I said, when you use fentanyl, it has lower incidence of post-operative nausea and vomiting compared to fentanyl. So you must put all this into consideration because you wouldn't want the patient to have this post-operative nausea and vomiting after the surgery because it will make patient to sleep over, which is not the aim. In the elderly, use of total intravenous anesthesia with remifentanil and propofol is very fine. It is associated with more rapid recovery compared to fentanyl. In the inhaled volatile anesthetic agents, like I said, most commonly used for the maintenance of anesthesia, and the patient recovery and is smooth, and it will give you room to have fast, earlier discharge from the hospital after the procedure. Sevoflurane has rapid induction of anesthesia in adults and also in pediatric patients. But this fluorine, when you use it to maintain the anesthesia, it gives you faster emergence than other inhalational agents. Rapid recovery of cognitive and psychomotor function is better with desflurane. Better postural control is better with desflurane compared to propofol. So if you have desflurane, use it. Then the airway management during ambulatory anesthesia. Face mask can be used when you're dealing with pediatrics, such as pediatrics coming in for hemiotomy, you're doing total intravenous anesthesia. You can use face mask to give oxygen, or you can even use the face mask to conduct the anesthesia with inhalational anesthetic agent. Use of laryngeal mask airway is also good for both pediatrics and adult patients. Use of reinforced laryngeal mask airway can be used if you're doing ambulatory anesthesia on head and neck. Avoid tracheal intubation if possible because of the problem of extubation stridor that may occur. If it is possible, avoid the use of suxamethonium, especially in the healthy adult patients who are muscular, because it can cause post-scoline muscle pain. Instead, if you have mivacurium, you can use it. It will offer you a better muscle relaxation. Analgesia, like I said, multimodal is better. This will help you to reduce the quantity of opioids you are using because of the problems of opioid. So you can use diclofenac 1 milligram per kg. You can use ibuprofen 5 milligram per kg. Paracetamol can also be used. You give a loading dose of 20 milligrams per kg, or you give 40 milligram rectal after induction of anesthesia. Short-acting opioid like fentanyl or afentanil can also be used. Like I said, these are the opioids and their dosages. Regional techniques can be used to conduct ambulatory anesthesia. Most often, you can combine it with GA, like if you want to achieve post-operative analgesia, you can do local infiltration with your GA, or you infiltrate the line of incision of the after the procedure. You can also do nerve block and still do your GA. This will offer good post-operative analgesia. Intravenous regional anesthesia, Beer's blood, can be used, especially for procedures like ganglion excision and other short procedures at the wrist level. You can also use spinal anesthesia using low dose of local anesthetic agent combined with adjuvants to be perfect, like hysteroscopy, where you can use that. It gives you a very good anesthesia and analgesia. Local anesthesia, wound infiltration, like I mentioned, can be done. Peripheral nerve block, like a penile block, ilioinguinal block, iliohypogastric block for hemiotomies can be done. Caudal block, whereby you use your local anesthetic agent, inject it into the epidural space via the sacral hiatus, is very important. It's good for children undergoing hemiotomy or opidopexy. It offers good analgesia, and at the end of the day, patient go home on the same day of surgery. There are advantages that these regional techniques offers to the patients. It improves quality of recovery. There's less pain, mainly less post-operative nausea and vomiting. Unplanned hospital admission is reduced. Able to observe the procedure. There's communication with the surgeon during the procedure. Option to receive light sedation or not at all is there because patient is awake. Patient has earlier ambulation. There are also advantages to the surgeon and the hospital. Fast track of recovery, where patient avoid being taken to PACU, and patient is discharged home directly. This regional will offer you less requirement for post-operative surgical staff and less requirement of drugs. So there's less chance of adverse reaction, and it is economical. Disadvantages of regional anesthesia for ambulatory surgery. It takes time to establish. Patient needs to be very cooperative because it is a technical technique. Risk of complication, there may be nerve damage, especially during the nerve block, or there could be transient neurological syndrome. Sometimes after spinal anesthesia, there could be failure because you do it, but if you do it under ultrasound guidance, the failure rate is reduced. Then there may be urinary retention with spinal anesthesia. Monitored anesthesia care is another type of technique to conduct ambulatory anesthesia. It is described as a specific anesthesia service for diagnostic or therapeutic procedure performed under local anesthesia, along with sedation and analgesia, titrated to a level that preserves spontaneous breathing and airway reflexes. The standard of care for patients receiving monitored anesthesia care should be as for patients undergoing general anesthesia or regional anesthesia. This includes you must do your preoperative assessment. Intraoperative monitoring is also important. Then post-operative recovery care should also be offered. There is a concept of fast tracking. By fast tracking, it means bypassing the post-anesthesia care unit after ambulatory surgery. This will enable patients to recover and go home faster. There are criteria to determine when patients should be fast-tracked. Level of consciousness. These are the criteria used: level of consciousness, physical activity, hemodynamics, respiration, and they are assigned numbers 2, 1, 0. For the best 2, then lowest 0. We have when patient is awake, well-oriented, 2, arousable with minimal stimulation, 1, then responsive only to tactile stimulation, 0. For physical activity, patient being able to move all the extremities on command, 2, some weakness in movement, 1, unable to voluntarily move extremities, 0. In the hemodynamics, blood pressure less than 15% of the baseline mean arterial pressure, 2. BP between 15 to 30% of baseline mean arterial pressure, 1. Blood pressure greater than 30% or below the mean arterial pressure, 0. Respiration, able to breathe deeply, 1. Tachypnea with good cough, 1. Able to breathe deeply is 2. Tachypnea with good cough is 1. Dyspnea is 0. Then oxygen saturation. When a patient is able to maintain oxygen saturation on room A greater than 90% is 2. If he requires supplemental oxygen via nasal pump to maintain this saturation greater than 90% is 1. But if the saturation is less than 90%, despite the oxygen supplementation, it is 0. Post-operative pain assessment, there is none or mild discomfort, 2. Moderate to severe pain requiring IV analgesics, 1. Persistent severe pain despite the analgesics given, 0. Post-operative nausea symptoms, when there is none or mild nausea with no active vomiting, 2. Transient vomiting or retching, 1. Persistent moderate to severe nausea and vomiting, 0. Patient total score is 14, and this patient must score over 12 with none of those criteria patient scoring less than 1. This patient that will meet up this criteria of 12 should be fast-tracked. So patients should not pass through post-anesthesia care units. Other discharge criteria. There are actually 3 phases of recovery after ambulatory anesthesia. One is the early recovery, whereby this is the time interval during which patient emerges from anesthesia, recovers control of the protective reflexes, resume early motor activity. Then the intermediate recovery occurs in recovery room, whereby patient begin to ambulate, drink fluid, void, and prepare for home discharge. Then the late recovery. This starts when the patient has been discharged home, and it will continue until patient will have complete functional recovery, and the patient is now able to resume his or her normal activity of daily living. Anesthetics, analgesics, and antiemetics can affect the patient early and intermediate recovery, while surgical procedure has highest impact on the late recovery. Before ambulation is allowed in a patient after ambulatory anesthesia,
10 minutes more.
Patient receiving the central
10 minutes
neuralgia
more.
will be able to have normal perianal sensation, which is S4, S2. And that patient should have ability to plantar flex the foot, and they have proprioception of the big toe, knowing that this is what determines balance and equilibrium. There's what we call when patients discharge criteria. There are post-anesthesia discharge scoring system. This also helps us to be able to determine when patient will be discharged home. There are criteria based on the vital signs, ambulation, nausea and vomiting, pain, surgical bleeding. When these are all done and the patient is able to meet up with this criteria, then the patient will be discharged home. And note that that patient should be discharged home with a responsible adult carer who will accompany the patient to home, and the patient should be able to have functional phone in case there is any complication coming up at home. The patient should be able to contact the physician, the surgeon. In conclusion, ambulatory anesthesia has become an important subspecialty in so many health institutions, as it has helped to clear backlog of patients in the waiting list for some surgeries. With the advancement in the ambulatory anesthesia currently, such as the advent of ultrashock-acting anesthetic drugs, and the use of regional techniques with proper intraoperative monitoring, good outcome has been ensured. Also, morbidity and mortality have been reduced due to the full knowledge of the pharmacokinetics and the pharmacodynamics of anesthetic drugs in use by the anesthetists conducting this ambulatory anesthesia. Thank you. These are my references. Thank you very much for listening.
Thank you, Dr. Aniobi Vernatius, for your wonderful presentation. Dr. Aniobi has been talking to us for the past 40 minutes on the dot on ambulatory anesthesia and current concepts. He took us through the definition, saying that an ambulatory anesthesia is usually called day case surgery, anesthesia for day cases, for day case surgery cases. And he looked at the cases that are done. He classified them under different specialty: ophthalmology, ENT, orthopedic surgery, gynecology, and other specialty. Then he now also look at the facility design, which most of us usually call the HIFO design. That is hospital-based, hospital integrated, freestanding, and office-based. That is HIFO, HIFO design, hospital-based, hospital integrated, freestanding, and office-based. He also talked about the different procedures that can be done. He gave example and move on to talk about selection criteria. He talked about patients. He divided this into patients related, social related, procedure related, and anesthesia related. He also looked at advice to patients. Usually, what are the advice we give to patients? He looked at them under pharmacological and not pharmacological advice. Then he also looked at anesthesia proper for day case surgery. He talked about general anesthesia, the requirement and consideration, then regional and local anesthesia. So, but particularly in general anesthesia, it talked about the fast, that is fast using of fast acting, short duration drugs, whether opioid, induction agent, or muscle relaxant. So he finally, then subsequently, he talked about discharge criteria and fast track and tools for assessing discharge. Dr. Vernatius, thank you very much for your wonderful lecture. So the floor is, I want to, at this point, recognize the presence of the Honorable Chairman. Madam, do you have any word of encouragement to give us before we proceed to question and answers? I'm not seeing much question on the chat. So after Madam has finished her pep talk, I think we could, if you wish to speak, you raise your hand so that we can acknowledge you. But it is preferable that you type your question on the chat box. I will take the question one after the other. Thank you very much. President, please.
Thank you, Dr. Saheni. Thank you, Dr. Saheni. We thank the presenter, Dr. Vernatius Aniobi from UPTH. I don't have much to say other than to say that this is a very good lecture and it's an encouragement for us to get more involved with ambulatory anesthesia. So let us allow the floor open for comments and contributions and questions. I will talk more later if need be. Thank you very much. Well done.
Thank you. Thank you very much, Ma. The first question I'm seeing on the chat box here is Dr. Vernatius. He says, is there any center in Nigeria offering ambulatory anesthesia super specialty training? Subspecialty training. I don't know whether, probably I will throw the question to the house. Is there any center in Nigeria that is offering ambulatory anesthesia as a subspecialty training?
There is no center yet, to my knowledge, but I know that Professor Charles Semarinjaya did his fellowship in ambulatory anesthesia and obstetrics anesthesia, and he has a bias for ambulatory. So anybody training under him should tap on the golden nuggets of ambulatory. But as for a training organized like that, we don't have one yet. For now, with the WFSA, we're only doing obstetric and pediatric anesthesia, and even the two of them have been put on hold because of the COVID-19 pandemic. Thank you.
Thank you, Ma. So the next question is from Chinedu. Said,
sorry, Dr. Sahene, sorry. There are some previous questions. Can I read them out to Dr. Aniobi?
Okay, Ma. Okay, Ma.
Okay. Can neonates less than 60 weeks be post-conceptual age have ambulatory anesthesia? That's by Dr. Alero Ofuazi. Then Dr. Nkechi Okoje is asking, is pediatric anesthesia in pediatric anesthesia, what is the age limit for ambulatory anesthesia? The next question is, okay, Please, I want to know if epidural anesthesia could be used for day case anesthesia. Thank you. Thank you.
Okay, can I answer the questions? Hello?
Yes, you can go ahead.
Okay. Yeah, I will start with is epidural used for day case surgery? Actually, under ambulatory anesthesia, is not only for surgery and procedures. Like when you have a patient who has chronic pain, usually orthopedic surgeons give some epidural analgesic. So for that to be done, you have to institute the epidural with the towing needle. Then you don't insert the catheter. Once you are able to locate the epidural space, they will give their injection. This procedure usually will last at most 10-15 minutes. Then you allow patient to rest for like 20 minutes. You monitor the vital signs. Once patient is able, stable, patient goes home. So epidural can be used. It's one of the current concepts. Epidural can be used for ambulatory anesthesia. Then is pediatrics. In pediatrics, what is the age limit? Like I said in the presentation, age is not a barrier to ambulatory anesthesia. So at any age of pediatric patients, you can carry out ambulatory anesthesia, but you choose your technique based on the procedure or the surgery that patient is coming in for. So age is not a limit, does not create any barrier from carrying out ambulatory anesthesia. But the most important thing you should consider is the anesthetic technique, and if you are doing GA, you must use the ultra short agents and the analgesics to avoid post-operative complications that may now make patients spend time and be admitted overnight. Can the first question, can neonates less than 60 weeks post-conceptional age be subjected to ambulatory anesthesia? I mentioned it on the course of the presentation. That is a period whereby you have to be careful because these patients are prone to post-operative apnea, especially when there is also associated anemia. So it is the group that you have to be careful. You don't subject them to general anesthesia, a type of ambulatory anesthesia. If you must carry out ambulatory anesthesia, if it is the procedure amenable to regional technique, it's advisable to do that to avoid post-operative nausea, apnea. So these are my answers to the question. If there are other things any other person can add to it, it's welcome. Then,
I think that's all. There is more to it, except there are other opinions. There's a question here that is asking, said, surgeries done by surgeons alone in day case basis in our environment, can they be regarded as ambulatory anesthesia as far that is surgeries done by surgeons alone on day case basis? They didn't involve an anesthetist or could they be regarded as ambulatory anesthesia?
what I have to say here is that because in our environment, day case surgeries and anesthesia have not really been well established. That is why surgeons can just take patients in, do local infiltration, and carry out some of the procedures. But in an ideal setting, there's supposed to be an anesthetist. There should always be an anesthetist, even when you're doing monitoring anesthesia care. there should be an anesthetist who will monitor these patients intraoperatively, make sure that patient vital signs and the other things are stable, and that give surgeons the adequate calculated dose of the local anesthetic agent to be used for local infiltration, because some of these surgeons, they don't know the dose limits of local infiltration, because all they know is that they collect the local anesthetic agent, they do infiltration until they are satisfied that the patient does not feel much pain. Sometimes, not knowing when they have exceeded the required dose. So it's always better if there should be any procedure or surgery to be done by a surgeon. An anesthetist should be informed to avoid any, because even in going toenail exists with local infiltration, patient can run into trouble when there is a infiltration of the local anesthetic agent into the vessel, and the surgeon will not know what to do. They not know when local anesthetic systemic toxicity has started, and patient will be complaining, my mouth is I'm feeling some metallic test in my mouth or things like that. So I advocate that surgeons should collaborate with anesthetists to carry out their delicate surgery for the benefit of the patients to avoid complications.
So as far as anesthesia was administered to do the surgery, can be regarded as ambulatory anesthesia. Okay, there are other questions. Said one, okay, those that are asking for the slide, usually the webinar will be deposited in YouTube. So the YouTube link will be sent. There's another question here. Said, what is the difference between MAC, that I think is monitored anesthesia care? What is the difference between MAC and conscious sedation? What is the difference between monitor anesthetic care and conscious sedation? I guess MAC there mean monitor anesthetic care.
Okay, the MAC here, I presume, means monitored anesthesia care. Like as I define, it is when there is a specific service for diagnostic therapeutic procedure to be performed under local anesthesia along with sedation and analgesia, to be titrated at a level that will preserve patients' spontaneous breathing and the airway reflexes. So now, in conscious sedation, more or less is because in the monitored anesthesia care, there is also sedation part of it with local infiltration. So conscious sedation should be a subset of monitored anesthesia. So that is what I feel. Then, as long as the airway reflexes are preserved, patient is having spontaneous breathing, you just follow the patient to keep the patient calm. I think it's a subset of monitored anesthesia care. Some other person can throw more light if there is any other difference.
Yes, it's a subset of monitored anesthesia care. So there's another question. Please, if anybody have other contribution, can we make it? We can't. The floor is open. Okay. Dr. Vernatius, there's another question here. Say, I want to take it along with the monitor anesthesia care question. Said, throw more light on monitor anesthesia care. Where does office-based procedure fit in this concept? Please throw more light on monitor anesthetic care. Where does office-based procedures fit in this concept? I don't understand. What is it trying to say, that most office-based procedures are done under monitor anesthesia care?
No, it's not. Actually, like I said, after the way of the monitored anesthesia care, I've given the definition. You must ensure that the anesthetist is always there in the suit with the and all the monitoring parameters must be done using multi-parameter monitor. You don't just give the local anesthetic agent, sedate the patient, and walk away. You must stay there. We monitor the patients, the SpO2, non-invasive blood pressure, the other monitoring parameters that should be done. And you have to be there to show patient safety. Then also that it is to be done as a monitored anesthesia care does not mean that you will not have a chance pre-procedure with the patient. So you must see the patient before the procedure, a kind of pre-anesthetic assessment, which usually is done during the pre-anesthetic clinic. You'll be able to also, if patients, you take the history, patient has any allergy, any problems. So it's not that you will bring the patient in and then you give something and you walk away. So anesthesia care should be conducted as if you are doing your normal routine anesthesia until this procedure is over. The only difference is that you do not install filtration in addition to sedation and analgesia, then you maintain spontaneous breathing and the airway reflexes.
Thank you very much.
Office-based.
Continue, sir.
The office-based procedures are not really doing it, not really monitoring anesthesia care, because a dental surgeon, they just see a patient that needs tooth extraction, take the patient to the office, do it, and they are local filtration, extract the tooth, and the patient goes home. There's no anesthetic involved. So that is what I have to say on that. So if there are other things, so
yes, like monitor anesthetic care, like what the term said, it has components. So if the components are there, then it's monitor anesthetic care. There must be a continual presence of somebody monitoring the anesthesia. Then there must be anesthesia given. And there must be a monitor that is used to monitor. So when the components are correct, you call it monitor anesthetic care. Then, like you talk about sedation as a component, that which is the anesthesia. So if those things are there, then you say it's monitor. But if it's not there, it's not monitor anesthetic care. So the other, let me move to the other question.
Can I also make?
Okay, ma. Okay, ma.
This contribution. Can you hear me?
Yes, I can hear you clearly, ma.
Okay. Good afternoon, everyone. Once again, let me say this further that for Dr. Ochuko, who is asking that question, like the speaker said, conscious sedation is one of the things that is required under monitored anesthetic care, because by the time you're giving anesthesia, general especially, patient is hypnotized. So he's not having conscious sedation, right? He has a very high Ramsay sedation level, as in, he's not very conscious, he's not conscious. So now for monitored anesthetic care, you have many other various things you may be required to do as an anesthetist, which includes, like the speaker said, sedation, which we conscious sedation, analgesia, monitoring with all the various parameters, also oxygen administration. Some surgeons may just want you to just stand by and help administer oxygen to some patients. And of course, perhaps you monitor other things around the patient. Let me just clarify further by saying that. Now, for office-based anesthesia, I want you to know that office-based anesthesia can be done either by the surgeon or by the anesthetist. And like the speaker also said, some of those regional techniques that anesthetists offer for pain relief, they are done in office-based settings. And also some surgeons also do some minor surgeries in their offices. So I hope that is clearer. I hope that is clearer to you. So office-based anesthesia may involve anesthetists, may not involve anesthetists, may be just the surgeon alone who does what is within his own realm, as in it doesn't go deep into the extent of deep anesthesia. Thank you very much.
Thank you. The next question. It says, sir, is there any current concept in ambulatory anesthesia in preterm babies? I think you have answered this question, but you could still throw more light on it.
I've answered that. I've answered that question. In the previous question on the neonates, less than 60 weeks this year, and also in the pediatrics, what are age limits? So I mentioned two things. The current concept, their age is not the limit. The limit and the drugs and the thing we can the ambulatory anesthesia to be conducted on the units, inclusive and other age, age grades. So it's all about the current concept is actually one, we have to choose technique. If you are doing a general anesthesia, you select ultra short acting anesthetic agents. You avoid use of opioids alone to achieve your analgesia. You do multimodal. The essence is to prevent the complications that is associated with opioids. Then you use regional techniques, and then you select the local agents with you select low dose of local anesthetic agent with advance. These are the concept, the correct concept that you can employ to be able to carry out ambulatory anesthesia on all age groups and safely conduct it. The patient goes on the same day. Thank you.
Okay, thank you very much. I hope that question is well taken and understood. The last question I'm seeing here is, it said, please, sir, severe obesity versus morbid obesity, which is contraindicated in ambulatory anesthesia? Severe obesity versus morbid obesity, which is contraindicated in ambulatory anesthesia?
Well, morbid obesity of BMI greater than 40 parameters square can actually undergo ambulatory anesthesia. Like I said, the technique to use is very important. Not really the patient, because if the procedure the patient is coming in for is amenable to regional, and the regional technique using fine spinal needle of 26 or 27 G, and they use low dose of local anesthetic agent with that, you go ahead and carry out the procedure. If the technique is the one that will require general anesthesia, you select drugs that will have rapid onset, rapid emergence, and as long as patients, the procedure will also meet the criteria of not lasting longer than 90 minutes. So these are the things you must put into consideration. I think they can all undergo ambulatory anesthesia once you're able to set the technique and the anesthetic agents right now. Then anybody can throw more if there is any other concern. Thank you.
Thank you very much. There are no other questions on the chat. I don't know. Dr. Briggs, are there any other questions that you can see?
I think we have dealt with every question. I think we have dealt with everything. Thank you very much, Dr. Osaheni, for the beautiful coordination. I will now hand over to the president of the NSA, Professor Elizabeth Obolinwaso. Please take over. Thank you.
Thank you very much, Dr. Briggs. Thank you once again to Dr. Vernatius Aniobi. We want to say we appreciate the moderator, Dr. Asaheni. I want to say that these things are being brought to us by Dr. Briggs and her team of the Education Committee. So we also appreciate her for the coordination of the seminars, the webinars, together with Dr. Ronke Adeshian, Dr. Nkechi Okoje, and the other ESCO members. We really appreciate you for your time and your efforts. I'm supposed to announce the speaker for next week, but I don't have it right at my fingertips. So I will call on Dr. Briggs to give us an update on the topics for next week. Dr. Briggs, please.
Okay, it's Prof. Marenga Pressy.
Okay,
it's Prof.
okay.
Marenga Pressy, yeah, you know it.
Yes, he's talking to us about how to do a research proposal, a dissertation writing, I think. So we look forward to a very exciting and stimulating session next week. Please, let's encourage all our colleagues in the departments, fellows and residents, junior residents and senior residents, all to join that session. Even if you're already a consultant, it will help you in research to progress in the career. So please make it a date with us next week. There are some ground rules that we want to intimate members about when hosting a webinar, that you should, when you're being a speaker, you should stay in a quiet environment with good lighting, and it should be pre-recorded and sent to the team, Dr. Briggs and team, and then there should be a pre-run to avoid too many glitches for the when the webinar is being aired. And then the speaker will be on live to take the question and answer session, and he will work closely with the moderator and the coordinators. So those are the few things we have tried to put in place. There may be some other things that will be communicated directly to the speakers. Also for the participants, please mute your audio when you are not speaking, and you can remove your video to reduce the bandwidth because of connectivity issues. Those are the things I can remember for now. Dr. Briggs, are there any other updates about the ground rules?
I've virtually said it all. You have virtually said it all. Nothing.
Okay.
And well, people should try to have sufficient connectivity, sufficient
data,
backup,
data.
yes, and backup, so that if one fails, they can have the other one to back them up.
Okay, thank you so much. And we hope that if there are any other questions, during the week, you can contact any of us, and then you can also send an email to the NSA secretary, who will respond appropriately. And of course, on the WhatsApp groups, you can also share your views, and also on the Telegram group. There is also the YouTube channel. I noticed that members are not subscribing to the YouTube. and even to checking the NSA website. Please, can we post the NSA website for members to see, and also the YouTube link? I want to talk to members about the WCA, that is the World Congress of Anesthetists, holding in September. The WFSA is sponsoring 500 anesthetists from low middle income countries to attend the conference free. And all we need to do, residents are to register for free, and consultants are just to ask for a letter of recommendation from the society, and they will be given the letter, and then they will be able to be given the scholarship. Please, adequate use of this. Council of WFSA has told us that the numbers from Nigeria are not really enough. We need to have at least 100 people from Nigeria, and so far we have just about 20 consultants and not up to 30 residents applying. Please, let's make use of this opportunity. We still have 4 days to go, or 5 days. It will end on the 30th of June. It will close on the 30th of June. Please, let's make use of it. For the letter of recommendation, all you need to do is to pay your dues of NSA up to date, so that we can say, yes, this is a member of NSA and is in good financial standing. Please accord him or her the highest privileges by giving them the scholarship. That's all you need. Just pay your dues and you get the letter. So please, kindly make use of this opportunity. Thank you very much. Back to Dr. Briggs, coordinator. Yes, Dr.
Yes,
Saheni.
Please,
yes.
I know, but I just want to use the opportunity because they sent me the mail. They gave me the scholarships. Since you are talking about it, I think it may encourage other people to attend the Congress.
Okay, please you do so. Encourage all the people in your department. Tell all the consultants to apply. And tell all the residents to apply for free. They should just register for free. It's free for residents. If we can tell all the people in our department, my department, I don't know, they are still not coming up. Some have applied, some have not, but I guess we still have a few days. We can catch up. I know that Nigerians like last minute rush, but please, let's not do that. Let's still try these few days left. Thank you very much. Dr. Briggs, is there any other info?
No. Nothing more. Thank you very much.
Secretary, anything from the secretary? Hello, Nkechi was on before. She seems to have gone off. Okay. In the absence of any other business, we don't do closing prayers. Let's just ask for vote of thanks. Who is giving the vote of thanks? Is it the moderator or the coordinator?
I will.
Okay, so please, over to you.
Okay. Thank you so much, everyone. Thank you for being part of this session. And without you, our activities will be ineffective. So we want to thank you for always being there. We want to thank the various people who are working with me, Dr. Adesina, Dr. Nkechi, and also the president herself, who keeps encouraging us. Thank you, the moderator. Thank you for doing a good session, and also to our speakers, including Dr. Aniobi for today. Thank you so much, every one of you. We appreciate you all. Thank you so much. Good night.
Good night, everybody.
Bye. Thank you.
Bye. Thank you. Bye.
Bye. Thank you.